Hello, this is Dr. Rayner. Welcome to this presentation on managing patients with behavioral health crises in primary care. Here are the objectives for this presentation. We're going to focus on defining behavioral health crises in primary care, discuss the crisis response guidelines, the way they are currently and future state, explain effective strategies and interventions for patients in crisis, and describe mental health first aid and the importance of CPR for mental health. What this statement is talking about is the crisis of crisis care in the United States. Really, crisis care has not been well coordinated, and it is even in many communities and in states across the country, it's almost non-existent. And if it is there, it's very sketchy and really needs to be transformed. By definition, crisis care is having the available resources and services that align with the needs of the person when the person needs it most, and that is when they're in crisis. The way crisis care really should work is when 911 is dispatched, there should be a designated crisis center. There should be a coordinated effort to help people in crisis. But unfortunately, that is not in most communities. It's virtually non-existent in most states. So when you think about the future of crisis response, there's an awful lot of interest and research and money now flowing into communities to help this coordinated effort. It's important because when you think about it, there is estimates that suggest that 25 to 50% of all fatal encounters with law enforcement involve a person experiencing mental health illness. And so with those statistics, we're really focusing much more on a coordinated emergency response that really addresses mental health crises. So what does that mean for primary care providers and family nurse practitioners? Well, family nurse practitioners are for the most part on the front lines in community health centers, in primary care, in urgent cares, and we're educated to treat the whole family. So when we're seeing that patient for the first time or in follow-up, we're really thinking about the holistic family, and we're looking at that person within the context of their family, as we have discussed many times. So if someone in the family is in crisis, it's certainly going to impact the patient. And it's really important for FNPs to teach lay people, teach our patients to recognize and not stigmatize mental and behavioral health problems. And that's really the most important takeaway from this presentation. Because if you think about it, all those people that don't have access to good crisis care, you'll probably be seeing at some point or another. People will seek care, but it may not be in the most appropriate setting. So for example, they may wind up in the community health center or in the primary care office in a mental health crisis, and they may not have had access to go to the emergency department or a behavioral health crisis center, which of course there's only a few in the city to begin with. Here are some of the common psychiatric presentations you may see in primary care. Panic attacks and anxiety are by far a big one. People present with all sorts of problems and symptoms that can be traced back to anxiety. Of course, a lot of other illnesses and diseases have to be ruled out before you can just say that it's a panic attack or anxiety. Some people know they have panic attacks, they know they have their trigger, and they may come in saying that they're having a panic attack. But other times anxiety can manifest itself as other physical symptoms. Suicidal thoughts and behaviors, of course. Sometimes family members will bring the patient in to even an urgent care or a walk-in clinic if they deem that the patient is in crisis. There's also a good amount of patients who will present with non-suicidal self-injury, so lacerations, for example, maybe a day or two later with a laceration. and they may or may not tell you that it was self-inflicted. We also can see people with acute psychosis. They may be hearing voices or having other hallucinations or delusions, and that may be acute. Again, they may be brought in by other family or friends. And of course, there's a lot of substance abuse, overdose, withdrawal from alcohol. Many times you'll find people come into urgent care with, or into the walk-in clinic with itching all over, and you quickly realize that they are in withdrawal, or some other vague symptoms of anxiety, which can then be traced, or nausea, for example, that can be traced to alcohol withdrawal. And of course, other substance abuse or drug seeking behaviors. And that's just to mention a few. One of the areas in primary care that's getting a lot of interest right now and really trying to have more of these practices is the integrated care model of primary care, where both a patient's physical and mental health can be addressed all within the same practice. So if you're seeing a patient who then you determine has a behavioral health or maybe in crisis, mental health crisis, you can have them also seen by a mental health professional within the same practice, or even sometimes that same day, or at least have them be seen by a social worker. There's an interprofessional team available. That is not widespread, however, and there's much more push to have this become a reality, but there's many barriers as well. So we'll talk a little bit more about that. And also being trauma informed. So whether it's an integrated care model or a primary care model, it's very important to meet people where they are and show empathy. And we'll talk about some of the approaches to this, but to actually have a trauma-informed care approach to practice. And I should say that with the numbers of people, 1 in 5 adults are thought to have at least one, if not more, adverse childhood events. And so with the prevalence of trauma, we always have to be thinking that we are providing care in a trauma-informed way. There's a lot of challenges in being able to provide good crisis care and good behavioral mental health care within the healthcare system that we're currently in, and most of that revolves around stigma. There's many communities who do not want needle exchange programs, for example, or safe drug injection sites. There's a lot of stigma around mental health diagnoses, and there's definitely a lack of resources, and that revolves around the workforce that is available to provide behavioral mental health care. And I would encourage you to talk with your preceptors in the practices that you're in, because there's a wide variety of approaches to behavioral health care. Most antidepressants and anti-anxieties are prescribed by primary care providers. However, many primary care providers do not want to provide those diagnoses and also those prescriptions. And even in the emergency department, for example, we would not just prescribe, we wouldn't initiate, but we also would not refill psychotropic medications. So there's a lot of variation, as I said, and it would be interesting for you to, at this point in your learning, to find out some of those variations. But also there's a lot of policies that need to be changed, and a lot of restrictions. Even within the same practice of an integrated care, for example, there are limitations on the information that you can share related to a patient's behavioral and mental health. So even those integrated care practices are not always available to, or always able to share all information about the patient. making it very, very difficult to provide integrated care. Now, when we talk about crises and behavioral health crises, SAMHSA is really the lead organization or the lead agency. It's the Substance Abuse and Mental Health Services Administration. It's within the U.S. Department of Health and Human Services, and it really leads the public health effort to advance behavioral health. This is the agency who has advanced the national guidelines for behavioral health crisis, and you're hearing it here now, but you will hear much more about this because within the next few years, the availability of integrated primary care, the availability of a more systematic approach to crisis, and just community-based mental health services will be much more talked about and become much more widespread. This is the same organization that has the National Suicide Prevention Hotline, and if you don't have that on your speed or in your favorites yet, there it is. So have that readily available. So what do we do if we find that we have a patient who we're talking about, who we're seeing in primary care, and they seem depressed, and we ask them, or we do a depression screening, and we ask them, are they feeling like they might want to hurt themselves or someone else? And we identify that they are in a crisis or that they may be suicidal. Well, the first thing you might be thinking is, I have to call 911 immediately, and that's the right thought. But we also have to make sure that the patient consents to everything that we do. So in being informed consent, if there's a family member there, we need to ask permission to talk to that family member. I have been in the situation where I've been doing a site visit for a student who in your program who came back out of the patient's room, and it was in a pediatric office. Who came back out and said that there was an adolescent who was suicidal, and the preceptor went through all the moves of talking to the patient, getting consent, talking to the family, and then having that patient transported out of the clinic. So there's a lot of protocol. It's not just a simple 911 call. And what we think of as emergency services, we activate EMS, and then we transport that person to the emergency department. Unfortunately, there's not many transports to a crisis center happening. As I mentioned, there's really not crisis centers where patients have a lot of access to for crisis. But EMS is for anyone, anywhere, anytime. So if you ever feel that a person is a threat to themselves, a threat to someone else, that they are in a crisis in terms of suicide, or they just can't function, or they're delusional, or they're hearing voices, just get them to the emergency department, and then they can handle it from there in terms of crisis, because that's really the one thing that we have at any point in time to help that patient. Now, we will talk a little bit more about mental health first aid, and but really being able to identify a crisis and getting that person to the next level of care is really what we're talking about and what's so important. And then what happens? So within the new guidelines, there is a new number of 988 that's going to come out in a few years. I guess they're going to have it widespread for mental health and suicide crises, and that will, so 911 would be for everything else, and 988 would just be for mental health and suicide crises. PCPs and all of us have to have good available go-to referrals. So we should have a good psychiatrist that we can refer people to. We need to have referral to psychotherapy. If we're starting antidepressants or anti-anxieties, we definitely need to have people seeing and following up with for therapy. There's a lot of education around medication management for psychotropics. And again, that whole medication management. Many times people will come in and say, well, I was taking, something for depression. I was on Zoloft and it really wasn't doing anything, so I stopped it. And many times people will go on and off their medications, and that is a big concern. So, and you'll spend a lot of time on education around medication, and people may come in asking for something for nerves or something for anxiety, and we have to very, very cautiously prescribe things. But there's a lot of problems with prescribing benzos. There's a lot of substance abuse around benzodiazepines, so it's a big challenge in primary care. It's also very important to have a collaborative and team approach. So if you have a situation where you can have a psychologist on site or a psychiatrist that sees patients in the health center once a month or something like that, that's great. But again, not many people have that right now. I mean, at Jefferson, we have access to psychiatry. We can refer people, but that doesn't happen all the time either. So again, it goes back to having really good available resources, know who you can refer people to, and really being in tune with identifying people who have behavioral health problems and who might be in crisis or heading into crisis. So some of the things that are important for primary care for behavioral health needs is really address recovery needs. So if we identify substance abuse, really help people get to recovery, have them come back, whatever it takes to help them get into recovery. Trauma-informed care is another important aspect of primary care, and you'll get some other information about trauma-informed care throughout the program. It's really an approach to care where we seek to treat the whole person, have a lot of empathy, and really not re-traumatize in any way when people seek care. We need suicide safer care. That's a SAMHSA new term, and really being tuned into asking people all the time about their mood, if they're depressed, and if they have any thoughts of suicide. And then, of course, mental health first aid. So mental health first aid is what we call CPR for behavioral health. And we're not trained in psychiatry as FNPs. We're not there to provide psychiatric care per se, but it is a technique, a strategy to be the provider or the layperson that can help get somebody to the next level of care. So being tuned in to whether or not this person is having a crisis, and then taking the necessary steps to help that person get to the right level of care. And here's the definition of mental health first aid. So it's the full course that would help to identify, understand, and respond to signs of mental illness and substance use disorder. And the training gives the skills to reach out and provide initial help and support to someone that may be having a mental health crisis. It's not rendering psychiatric care. That's the most important part of this. So one of the most important things that we can do as nurse practitioners that are not psychiatric providers is to really pay attention and listen and really empathize with someone. It may be disingenuous to say, well, I understand, or I know what you're going through. We probably don't want to say that. But if we can be there right in the moment with the person, listening very closely to what they're saying and to acknowledge what they're saying and be active listeners, then we can convey to them that we really are caring and helpful. And this is a very important part of the helping relationship to really help that person in crisis. and it will and that is the important part of having this shared experience, or this building this relationship with the patient. So I hope that gives a little bit of insight into behavioral health crises in primary care, and helping people to get to the next level of care if they need it. If you have any questions, please feel free to email me, sharon.rayner@jefferson.edu. I'm happy to answer any questions that you have. Thank you for listening, and please feel free to reach out if you have any questions about this presentation. Thank you.